I will see the pharmacokinetics of the drug, in the sense what is happening to the drug in the body. So once we take the drug, what is happening to the drug. So here if we see the study of disposition of the drug. So once the drug, it is getting disposed, in the sense the drug is getting undergoing various mechanisms. So if we see the disposition of the drug, it is undergoing by a process called ADME, that is absorption, distribution, metabolism and elimination. So this elimination, it includes two processes, that is excretion and toxicity. So here excretion, in the sense the drug is removing out of the body, and if whatever the uneliminated drug, or else which is not excreted out, or else if it is not excreted, if it is remaining in the body, then it is showing toxicity. So if we see here the flow chart, so once the drug is administered, so it is dissociating and the drug is getting absorbed into the body. So once the drug is getting absorbed, it enters into the plasma. And once the drug is entering into the plasma, it undergoes the process of distribution. So here the drug which is there in the plasma, it is distributed all over the body, and then the distribution, it is taking place into the cells or into the tissues, and then the drug is undergoing metabolism. So there are various metabolic enzymes which are present in the body, and thereby they are breaking down the drug and new metabolites are formed, and then the drug is eliminated out of the body in the form of metabolites through fecus, urine or bile. Why the drugs are getting failed? So here if we see, all drugs do not show the effect. So in few cases the drug fails to show its effect. Why? Because 39% of the drug failed because of the pharmacokinetic reasons. So if the drug is not either absorbed properly or distributed or not metabolized properly, then the drug fails to show its effects, and 11% is because of the animal toxicity. So because here before we are testing, or before the drug is marketed, we are doing animal testing. So if it is showing toxicity in animals, then that drug is not marketed. So that is the reason it is failing. And miscellaneous reasons, there are various other reasons, and adverse effects in man because of its various side effects, so that include 10%, and commercial reasons because of the money, because of the cost effective reasons, or because it is not available so easily, the drugs are failing, and that is of 5%, and lack of efficacy. Few drugs, they do not show effect at all in the body. So because of all these reasons, the drugs are failed to show their effect. Why we have to study PK studies? So why the pharmacokinetic studies are to be done? So one thing is that because the toxic drugs may accumulate. So here once the drug, why the PK studies are important? Because so once the drug is entering into the body, we should know how toxic it is to the body and how it is efficient to the body. So if it is highly toxic, we should stop giving that drug. So in order to measure the toxicity of the drug, these PK studies are important, and it is even used to measure the beneficial effects of the drug. And a drug can be rapidly metabolized. So even the metabolic capacity of the drug can also be studied with the help of these PK studies. So these patients, so most of the patients, they have the toxic effect of the drug, or they have beneficial effects of the drug, or they have highly metabolic effect of the drug. So all these can be studied with the help of this pharmacokinetics. So now let us see how the drug is administered. So there are various routes of administration in the man. The routes of administration are either parenteral or enteral. So through parenteral route, it is given in the form of injections, it is given in the form of topicals, and it is given in the form of inhalations. So here parenteral means the drug is directly entering into the systemic circulation. So if we give through injection, it directly goes to blood. If we give through inhalations, it directly enters the systemic circulation, and if we apply it topically also, it is entering into systemic circulation. And enteral route in the sense, first the drug has to go orally, it has to pass the stomach, it has to go to liver, and it has to undergo metabolism. Then only the drug is entering the bloodstream. And the routes include rectal route and oral route. So if we see the process of pharmacokinetics, first thing is absorption. So once the drug is entering into the body, it undergoes a process of dissolution. So it is getting mixed up with the fluids which are present in the body, and then the drug is getting absorbed. It is in the sense the drug is after it is entering into the body, it is entering into bloodstream. From the bloodstream, it is carried into different tissues. So this process is called absorption, and this absorption studies are important to know the therapeutic effect of the drug. And they are also, most drugs, so most of the drugs, 90% of the drugs are gastrointestinal absorbed. So they are absorbed in the abdominal or gastrointestinal region, except IV drugs, because IV drugs, they enter directly into the bloodstream. If we see the process of absorption, this process of absorption is taking place by two mechanisms. So one is passing through the membranes to reach the bloodstream. So it will directly pass through the membranes and it is reaching the bloodstream. This is called active diffusion and passive diffusion. This passive diffusion, in the sense it needs some carrier molecules to get transported into the blood. So if we see, this is the plasma membrane structure. So this plasma membrane, it is having the phosphobiolipid layer. So it is having lipid structures in it, and it is having integral proteins, peripheral membrane proteins, cholesterol and channel proteins which are there. Through all these proteins, or through all these channels, the ionic molecules or drugs are entering into the plasma membrane. If we see the mechanism of absorption, there are various mechanisms, that is passive or simple diffusion, active transport, pinocytosis and facilitated diffusion. So, simple diffusion or passive diffusion. So simple diffusion or passive diffusion is nothing but most of the absorption takes place through the simple diffusion, where the drug is getting transported directly into the plasma membrane. So the drug directly, it enters into the plasma membrane without any carrier, and the substances move across the plasma membrane based on the concentration gradient. So if the concentration is high extracellularly, the drug moves outside to inside the cell, and if the concentration of the drug is present high inside the cell, then the drug molecules move inside to outside the cell. So it is purely based on the concentration gradient and rate of diffusion, how fastly the molecules are getting diffused inside or outside the cell. And here no energy is required. That is the reason this is called passive diffusion, where it is not utilizing any energy. If we see here, this is the diagrammatic representation. So no carrier proteins are involved, no energy is also lost. So the molecules which are in blue color, they are present in the extracellular space, and they are directly entering into the plasma membrane, into the cytosol cell. The other one is active transport. So this active transport, it is based against the concentration. So it is based on the electrochemical gradient. In the sense, here it is based on the against the concentration. So if the concentration of molecules is high here, then the molecules move against the concentration. So they move into the higher radius more when compared to lower, and this requires ATP. So it requires some energy. It requires, the drug molecule needs some energy for them to get transported. If we see, this is the diagrammatic representation here. The sodium is moving inside the cell with the utilization of the ATP, and it requires some carrier protein. So the carrier protein here is nothing but the carrier or channel proteins which are present on the plasma membrane. These active transports, the transporters or the carrier molecules which are there, these are of three types in active transport. One is uniport, symport and antiport. Uniport is the one which will allow only one molecule to get inside it, only unidirectional. One molecule will go in same direction. And if we see symport, here the carrier, it will carry two drug molecules. It will allow two drug molecules in the same direction. And antiport is nothing but the movement of two molecules in opposite direction. So if one molecule is coming inside the cell, the other molecule will go out of the cell. The other one is facilitated diffusion. So facilitated diffusion is the one which is needed some carrier proteins. So it will need some carrier proteins, and net flux of the drug molecule movement is from high concentration to lower concentration. So here If we see the active diffusion, the movement is against the concentration. But here, the movement of molecules is from higher concentration to the lower concentration with the help of the carrier proteins. And facilitated diffusion will not require any energy at all. So, the difference between passive diffusion and facilitated diffusion is that they both don't require energy, but the thing is facilitated diffusion, it needs some carrier proteins. If we see facilitated diffusion, so through these carrier proteins, the drug will bind to the carrier proteins, and then this carrier proteins release the drug into the cytoplasm. The other process is pinocytosis. So most of the drugs which are having the molecular weight of greater than 900 Daltons. So if the molecular weight of the drug is more than 900 Daltons, then that type of drugs will undergo the absorption of pinocytosis. Pinocytosis in the sense here, the plasma membrane which is there, it forms some loops in it. So when these loops are formed, because of the protrusions which are there inside the plasma membrane, the drug is absorbed. So the drug is absorbed into the loop, and thereby the plasma membrane closes and it forms a vesicle. So first the plasma membrane goes inverted, and the drug molecule is trapped in that, and this inverted protrusion which is there, that is forming into a vesicle, and from that vesicle the drug is released into the cytoplasm, and this process also requires energy. If we see the capacity or else if we see the activity, IV versus oral. So in the IV, drug absorption is immediate when compared to oral, and the drug absorption is complete up to 100% in IV administration when compared to oral administration. The rule of 5. So while formulating, we have to follow the rule of 5. So what is this rule of 5? So here, poor absorption or permeation. So if the drug is having poor absorption, or if the drug is not properly permeated to the plasma membrane, what are the defects it is having? There are more than 5 hydrogen bonds. So here the drug should not have more than 5 hydrogen bonds in order for it to get betterly absorbed, and the molecular weight should not be greater than 500. And the log P value should not be greater than 5, and there should not be more than 10 hydrogen bonding receptors. So here these are the 5 the rule of 5. So these 5 things have to be considered in order to formulate a drug for better absorption. The absorption and ionization, how this process is taking place. So here, the non-ionized drug which is there, it is more lipidly soluble. In the sense, the drug which is there, it is not forming ions like sodium, potassium, calcium. It is not having any charge on it. So these non-ionized drugs, they are lipid soluble. They are having lipidic in nature, and they get rapidly absorbed into the plasma membrane. Whereas the ionized substances which are there, the ionized molecules which are there, they are not that easily soluble, or that is the reason they are not crossing the plasma membrane so easily. The other one is first pass metabolism. So what is this first pass metabolism? So the drug, it is entering into the oral route. So once it is entering into the oral route, it has to pass to stomach. From stomach to liver, it is undergoing metabolism, and it is reaching the systemic circulation. So in this process, so once the drug is reaching the oral route, there the drug is getting degraded, only few amount of drug is released. And once it is going into the liver, it is getting metabolized. There by metabolic process, few amount of drug is released. So here, after the dose is there, the drug is destroyed in the gut, and it is not absorbed, and there it is destroyed by the gut wall again while it is passing the gut wall, and finally when it reaches to liver, only few amount of drug is reaching the systemic circulation. So if 100% drug is given, only 40% is reaching the systemic circulation. So this type of mechanism is called first pass metabolism. What are the factors which are affecting the absorption? So here the aqueous solubility. So here if the drug is highly soluble in water, it is not absorbed so easily. And concentration of the drug, if the drug is in more concentration, it is absorbed very easily. Area of absorbing surface, the surface area should be more, then only the drug will get absorbed easily. Vascularity, so there where the absorption is taking place, it should be highly vascular, then the absorption takes place more. And route of administration, so all these count into when the drug is getting absorbed. Another one is bioavailability. So what is bioavailability? Bioavailable. So the amount of drug which is available in the systemic circulation. So this bioavailability plays a major role in the drug absorption because the bioavailability is more, that is up to 1 while we give through IV route, because the drug is entering directly into the systemic circulation. And if we see the bioavailability of the drugs which are done through oral route, it is having less than 1. You see, this is the this is the graph where the bioavailability is plotted. The red coloration indicates IV route, which is having higher bioavailability, and that is through oral route where it is having low bioavailability. Now let us see the distribution, how the drug is getting distributed. So here the movement of drug from blood to various tissues. So once the drug is absorbed from the blood circulation, the drug is distributed to various tissues in order to show its effect. And this distribution is determined by various factors like partitioning across the membrane. So the partition which is there, so the partition where the drug has to cross. So that is determining binding to the tissue components. So the drug should be able to bind to the tissue components. Binding to blood components, the drug should have affinity to bind to RBC, because these RBC or plasma proteins, they will bind to the drug and they will displace the drug at this site. So if they are binding in the blood, once they reach the liver, they release the drug there, and thereby the drug is entering into the tissue. And physiological volumes. Total body water. So what is this total body water? Here, once the drug is entering into the body, the drug, it is solubilizing with water. So here the drug water which is there, it is distributed all over the body. So if we see, if the drug is highly vascular, 3 liters of drug water is getting there. Extravascular 9 liters. And intracellular is 28 liters. Here the percentage of body water which is there in vascular is 4%, and extravascular body water is 13%, and intracellular body water is 41%. So here where the body water is high, total body water is distributed in this way. So here at these parts the drug is getting distributed. So if we see the apparent volume of distribution. So apparent volume of distribution is nothing but dose administered through IV route divided by plasma drug concentration. So what is the dose administered? If we divide it by plasma concentration, whatever the result we get, that is the volume of distribution. So how much drug is distributed into the body? So if we take the volume of distribution of values for few drugs are, cocaine is having volume of distribution of 140, clonazepam 210, amitriptyline 1050, amiodarone 5000. So in the sense, amiodarone is greatly distributed when compared to other drugs. What are the factors affecting volume of distribution? One is lipid water partition coefficient. So if we take lipid and water, so how much, if the drug is highly lipid soluble, then it is getting more distributed. If the drug is highly water soluble, then it is getting less distributed. pKa value, that is partition coefficient value, in the sense the amount of drug which is distributed in both two immiscible liquids. And degree of plasma protein binding, if the drug is having high plasma protein binding, it is highly distributed. And affinity for the tissues, it should have greater affinity to the tissues and thereby it is getting distributed. Fat levels and disease conditions like congestive heart failure, uremia and cirrhosis. So in all these conditions, the drug is not getting distributed so easily. Another one is blood-brain barrier. So here the blood-brain barrier, the disruption by means of osmotic pressure. So here if a drug has to pass through the blood-brain barrier, it has to undergo the process of osmosis. Osmosis in the sense the movement of molecules from higher concentration to the lower concentration through a semi-permeable membrane. So here the blood-brain barrier is acting like a semi-permeable membrane for the drug molecules to move inside out to into the brain, and this is blocking of active efflux transporters. So if the transporters, efflux transporters are there inside the brain or else in between the blood-brain barrier and the drug, and then these efflux proteins, they throw out the drug. So they won't allow the drug to be inside the tissue for longer period of time, or they block the entry of the drug. And intracerebral implantation. So in all these conditions, the distribution is affected. So this is the blood-brain barrier where the drug molecule is entering into the brain. The other one is plasma protein binding. So the drug should have higher affinity towards the plasma protein. So the drug will bind to plasma proteins, and these plasma proteins, they carry the drug molecule to their destination and they leave the drug molecule there. If the drug is having high plasma protein binding, then it is distributed more. Physicochemical properties. So physicochemical properties in the sense which determines the drug likes to go into the body. So if a drug is highly soluble in nature, or if it is soluble in oil, then the drug is distributed more. If a drug is soluble in oil more, then it is distributed less, because blood is the one which is watery in nature. So the drug should have hydrophilic capacity, because the drug is transported through water or blood. So this blood, if the hydrophilic molecules are distributed more when compared to hydrophobic molecules. The other one is size of the drug. So if the drug size is more, then it is not distributed easily. So most of the drugs are about 250 to 450 Daltons. So molecular weight. So at this molecular range, the drugs are easily distributed. Whereas if the molecular weight of the drug is increasing, then the distribution is not that easy. So, if the drugs are having greater than 200 Daltons and they are having low partition coefficient value, then they cannot cross the plasma membrane, and if they are not crossed, they need some specialized carriers to get transported. Now, let us see metabolism, how the metabolism is taking place. So once the drug is entering into the liver, because of the various enzymes which are present in the liver, it undergoes degradation process. So this type of process is called as metabolism. So the chemical modification of the drug. So here the drug, when undergoes metabolism, it becomes water soluble and thereby it is excreted out. The metabolism undergoes by two phase reactions, phase 1 reaction and phase 2 reaction. So phase 1 reaction is the one where the drug molecule or the parent compound is converted to polar hydrophilic compound, and it is this metabolism reaction occurs by addition of groups like OH group, sulfhydryl group, NH2 group, COOH group. So when these molecules or when these functional groups, they bind to this drug, and then thereby they will make the drug inactive. Phase 2 reactions include conjugation reactions and glucuronidation type of reactions, where the drug aqueous solubility is increased. Here if we see, this is the diagrammatic representation where the drug is there. The drug undergoes phase 1 reaction and phase 2 reaction. Phase 1 reaction include oxidation and reduction. Oxidation in the sense loss of electrons. Reduction in the sense gain of electrons. And in phase 2 reactions, we have the glutathione conjugation, sulfation, acetylation, glucuronidation type of reactions. So here, before the drug which is undergoing metabolism, it is undergoing metabolism with the help of the major enzymes called cytochrome P450 enzymes. So cytochrome P450 are the enzymes which are helping in the metabolism of the drugs. So they act structurally unrelated with the drug. So they are structurally not related with the drug, but they act in the metabolism of the drug. So here, if we see the cytochrome family, there are more than 50 isomers of the family. So here there are more than 50 families of the 50 subtypes of these cytochrome enzymes, but mainly there are 6 main enzymes which are acting. One is cytochrome 1A2, cytochrome 2D6, cytochrome 2C9, cytochrome 2E1, cytochrome 2C19 and cytochrome 3A4. These cytochromes, they are either inhibited or the action of these cytochromes can be induced by various drugs, like the drugs like cimetidine. So this drug, it is acting as an inhibitor of cytochrome P450. So it will inhibit the action of this cytochrome P450, thereby it is extending, or else it is extending the it will inhibit the metabolism of the drug, and thereby it is extending the efficacy of the drug. And inducers, so the barbiturates, carbamazepine like drugs, they will potentiate the action of this cytochrome P450, thereby more metabolism takes place, and blockers. So the drugs like microsomal enzymes like MAO inhibitors, so or anticholinesterase drugs. So these block the action of cytochrome P450, inhibiting the metabolism of the drug. So here if we see the inducers, so cytochrome 1A2 inducers are the cigarette smoking, if the person who is having more cigarette smoking, who has the habit of eating grilled meat, aromatic polycyclic hydrocarbons and phenytoin. So all these induce the action of this enzyme. And cytochrome 2C9 inducers are the barbiturates, phenytoin, carbamazepine and rifampicin. And the enzymes like cytochrome 2C19 and 2D6 are not, the action is not potentiated with any drug. And cytochrome 3A4 inducers are barbiturates, phenytoin, rifampicin, carbamazepine, glucocorticoids and griseofulvin. The inhibitors of these enzymes are cytochrome 1A2 inhibitors are cimetidine, ethinyl diestradiol, ciprofloxacin. 2C9 inhibitors are amiodarone, isoniazid, clotrimazole, cimetidine and ketoconazole. 2C19 inhibitors are fluoxetine and omeprazole. 2D6 inhibitors are amiodarone, cimetidine, fluoxetine and paroxetine, haloperidol and diphenhydramine. And 3A4 inhibitors are ketoconazole, erythromycin, isoniazid, calcium channel blockers, red wine and grapefruit juice. So these enzymes are inhibited, and these enzymes either may be inhibited or their action may be potentiated by the various drugs. The other one is phase 2 reaction. So phase 2 reactions are glucuronidation type of reaction. So here phase 2 is true detoxification. So where the drug is converted to inactive metabolite. So detoxification is occurring. The toxicity of the drug is reduced. Phase 2 reactions include glucuronidation, where OH, COOH, NH2 and SH groups are attached to the drug molecule in order to make inactive. Sulfuration, where NH2, SO2, NH2 and OH groups are attached. Acetylation, amino acid conjugation, glutathione conjugation, fatty acid conjugation and condensation reaction. So these are all the various phase 2 reactions where the drug molecule is undergoing. If we see oxidation reactions, so most of the drugs, they undergo the process of oxidation by the various enzymes. So here the drugs like caffeine, theophylline, paracetamol, propranolol, they are oxidized with the help of the cytochrome 1A2 enzyme. Phenytoin, antibiotics, oral hypoglycemic agents and NSAIDs, they are undergoing oxidation process with the help of 2C9 enzyme. And diazepam, propranolol and omeprazole, they are undergoing the oxidation process with the help of 2C19 enzyme. Beta blockers are undergoing the oxidation process with the help of 2D6. So here these drugs, they lose electrons. So oxygen is added and electrons are lost, and thereby they are forming inactive compounds. So the reduction process in the sense gain of electrons. Here it requires two molecules, FAD and NADPH. So here FAD is converted to FADH, NADPH is converted to NADP. So electrons are lost, electrons are lost, and thereby they are undergoing reduction process. So here the reduction include aldehyde reduction, and where the aldehyde reduction, the aldehyde group is added to that and reduction process is taking place. So these are the examples of the reduction process, aldehyde reduction and nitro reduction. Glucuronidation. So glucuronidation is a process where the glucose or else glucuronosyl group is attached to it. So here it conjugation to a D-glucuronic acid. So the compound which is there, D-glucuronic acid, comes and attaches with that, and thereby it is forming inactive compound. Excretion. Finally, after the metabolism takes place, it undergoes excretion process. So whatever the metabolite is there, it is waste product. So it is not useful for the body. So thereby it is excreted out in the form of urine, fecus and bile. So the main process is that body will eliminate the unwanted waste material. So common route is bile or urine, and the other routes is that the waste materials can be removed out through skin, through sweat in the form of sweat, and through lungs in the form of exhaled air. And the lipophilic drugs which are there, they undergo various metabolic processes and finally they are excreted out. Here we can see the renal clearance where the drug is entering into the nephron, where it is filtered and the drug is excreted out in the form of urine. Here we can see the renal clearance. So how we can estimate the amount of drug which is cleared. So here V is nothing but the volume of the drug which is collected in the urine, and Cu is nothing but urine concentration. T is nothing but duration time or else time taken to collect the urine, and Cp is nothing but plasma concentration of the drug. So if we put all these values in the formula called V into Cu by T into Cp, then we get the volume or else how much amount of drug is eliminated out through renal system. Elimination half-life. So here it is the time taken for the drug, for the 50% of the drug to eliminate out of the body. So here the T half is measured with a simple formula called 0.693 into Vd, that is volume of distribution by clearance. So here the elimination half-life in the sense it is time taken for 50% of the drug to eliminate out of the body. So if 50% of the drug is eliminated out, 50% is remaining in the plasma concentration. So time taken for the plasma concentration or the amount of drug in the body to be reduced to 50%. And thereby it is eliminated. So the T half is very important in order to find the toxicity or efficacy of the drug.